and welcome back to the Curbsiders. I'm Dr Monee Amin with my great friend and effervescent co-host, Dr Meredith Trubitt. On today's video, we're going to discuss psychiatry for the hospitalist based on a recent episode with Dr Aaron Gluth, who's a med psych physician at Emory University.
Yeah, Moni, lots of great tidbits and pearls from this episode. I think there's a wide range of comfort level for managing patients with comorbid psychiatric conditions. Dr. Gluth did such a great job at explaining why this should be important to the hospitalists, really framed like the why of some of our most common questions that arise on the wards. So do you want to get us started on what you think was like the most striking?
Yeah, by far, the most important thing to take away from this episode, I think, was the concept of the mortality gap, which is to say that 10 to 20 years less life expectancy for patients with psychiatric comorbidities. And the most important thing about this, though, in addition to that one, fact is that the deaths are more frequently from non-psychiatric conditions, and the common things being common, things like heart disease and diabetes. And I think, sometimes it's easy to get bogged down in the psychiatric illness of it all. But as an internist, if you can just reframe it as, hey, the actual medical conditions are actually what's going to be the cause of their death, and things that we handle all the time. And I think there's probably a misconception out there that patients with psychiatric illness only die from complications of their psychiatric illness, when could not be further from the truth.
Yeah. And I think the main takeaway then from knowing that is, when you're thinking about their workup and all these things that are largely coming as a risk factor because of the medications they have to be on, is that we really should be checking A1Cs and lipid panels on all of these patients. And I think, just like you said, this is kind of why it should be important to the hospitalist. This is definitely within our wheelhouse, definitely within things that we are comfortable with, and really highlights why we should care about it. The other pain point is all right, where should the patient go and where can they be best served?
Yeah. And I think if you're a hospitalist that has any percentage of patients with psychiatric comorbidities at your facility, this is a conversation that happens a lot between medicine and psychiatry. What is the safest thing for the patient? And psych floors are not just medical floors with, not medical patients. They're considered milieu units, which are really just a place where they're supposed to live and, participate in group and exercise therapy and all sorts of other things that are immersive. And if they have an acute medical illness, they're not really able to do that. If they have an IV stuck to them, if they even need oxygen, any of those things, that ties them to their room. And those things are also potentially safety hazards for the patient and other patients. And so framing it that way, again, I think helps you sort of tamp down some of your anxieties about it and just focusing on what's right for the patient.
Yeah, and I think just highlighting where those limitations exist, and that may be that the patient that you have is going to be best served on a medicine floor. But really, I thought Dr. Gluth did a good job at highlighting, this is a time then to incorporate into a conversation with your multidisciplinary team that you're going to have to take care of this patient on how can you get their ongoing psychiatric care to improve maybe their medical conditions, to maybe get them to that right milieu unit that they will need eventually. And it may take longer than you would otherwise have for someone who doesn't have that comorbid psych condition, but it's still really important to be thinking about that. The other big aspect that we talked about on this episode is really what's in the wheelhouse for the hospitalist, which is the famed reversible workup, and what is kind of where our money should be in on that workup.
Yeah, they're here with you now. They're on the medical floor. What now? And I think he did a pretty good job of laying out, the things that we work up are the things that are easily reversible. So syphilis, HIV, very treatable, very important to catch those. Also, he was a big proponent of maybe you can check thymine, but really just give it kind of thing. And then the less important one, really he felt strongly about was folate. And then vitamin D, he kind of went into this little thing about how it's kind of a chicken or the egg, is there psychiatric illness, preventing them from getting what they need to get better vitamin D levels and vice versa. it seems like every patient that comes in that is, quote, altered gets some sort of a CT of the head. And he illustrated nicely that that's maybe not always the case, but the two most important places that this is required would be patients that are on any kind of anticoagulation, and then patients that are in the geriatric population, and specifically because they tend to be a higher fall risk.
Yeah, and the only thing I'll add to the vitamin D comment is specifically he talked about it for if they are on anti-epileptic medications as their mood stabilizers. Those medications by themselves, same as like your other psychiatric conditions causing metabolic syndromes and needing to think about the A1C and lipid panel, the anti-epileptics can cause a low vitamin D and to replete for that.
Yeah, no, I think, again, trying to reframe it for medicine terms for you, I think just makes it so much easier and like takes the pressure off you to feel like, oh my God, I'm dealing with a patient with psychiatric illness. I think one of the lines that we came up was, you don't call a nephrologist for someone's creatinine being 1.4 if that's their baseline creatinine, right? And I think it's the same thing here. And we went into a lot more detail about this on the episode. So click on the link in the transcript if you want to hear the full episode. And with all that, I've been Dr. Monee Amin, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And I remain Dr. Meredith Trubitt. Thank you and goodbye.